Okay, doctors, we are live now. You can start.
Hello and good evening. Welcome to the expert crosstalk on the Empagliflozin, multi-pronged, multi-faceted and multi-benefits. As we already knew that ESC 2020 was memorable with the path-breaking clinical data presented from multiple global trials. This program is designed with the objective of dialogue between two different specialties, that is cardiology and endocrinology, which will bring upon two different ways to address the clinical complexities and the clinical cases in heart failure. So according to Emperor HF trial, does SGLT2 inhibitor can be considered as an important drug for heart? And for this, let me introduce today's speakers. Today's speakers are Dr. Prashant Ullas Kaduskar and Dr. Rajesh Surendra Badani. And I am a moderator, Dr. Shovin. Dr. Prashant Ullas Kaduskar is a consultant endocrinologist, Columbia Shire Hospital, Pune. And Dr. Prashant has a splendid academic achievement till date and has got a wide area of expertise that is about diabetes, pituitary and adrenal disorders, and has also got several national and international publications till date. I welcome Dr. Prashant in his expert welcome. And our next speaker is Dr. Rajesh Surendra Badani. Dr. Badani is a senior consultant interventional cardiologist and electrophysicist and also a patient safety officer in the Department of Cardiology, Aditya Birla Memorial Hospital in Pune. Doctor is also actively involved in teaching and lectures and also receives several prestigious awards and recognitions till death. And also he has several national and international publications in his credit. I welcome Dr. Rajesh in this expert web talk. And I'm handing over the session to Dr. Prashant to start with the presentation. Thank you.
Can I start?
Yes, sir.
Okay.
You're audible.
A very good evening to all the listeners. So as mentioned by the previous speaker, the talk is on empagliflozin, multiple benefits in multi-indications by multi-mechanisms. So as you all know, empagliflozin is a very important molecule in management of diabetes. But it's not only a molecule which is to control blood glucose. It has multiple other benefits. How, that is what we are going to see. So what are the benefits? What is the evidence for that? And how it forms an important place in management of diabetes as per the various guidelines. This is what we are going to see in today's talk. So we are going to have two perspectives, endocrine perspective and cardiology perspective. I am going to speak about endocrine aspects, that is how empagliflozin is known to control blood glucose, what is the evidence, and what are the current guidelines. What is the place of this molecule in current guidelines? So coming to SGLT2 inhibitors, the published strength of evidence for various molecules. So there are multiple molecules in pipeline, but as early as 2008 March, we had dapagliflozin, then remogliflozin, canagliflozin coming to empagliflozin, which showed a substantial evidence as to its beneficial effects on various aspects of metabolism. So before going on to molecule, a little bit about what is SGLT2 inhibitor and physiology in short. So as we all know, renal handling of glucose, almost 160 grams of glucose is filtered per day in a nephron, which is the functional unit of kidney. And almost negligible amount, that is less than 500 milligrams, is excreted. Now this reabsorption of the blood glucose is possible because of certain molecules called SGLT2 receptors. These are solute transport carrier family 5 protein molecules or receptors. There are multiple receptors, but important ones are SGLT2 and SGLT1. So SGLT1 resides in the proximal convoluted tubule of segment and segment 3, whereas SGLT2 receptor resides situated in S1 and S2 segment of proximal convoluted tubule. SGLT2 is responsible for 90% of glucose absorption, whereas SGLT1 is responsible for only 10% of glucose absorption. And hence, so in a state of diabetes where person is suffering from excessive state of glucose in blood, which is getting reabsorbed, the thought was, if we block this molecule, if we block this receptor, the excess glucose will get excreted and that's how the reduction will be possible. So as way back as 1960, this molecule was first found out to have an effect on absorption of glucose. So SGLT2 inhibitors reduce glucose reabsorption in the proximal tubule, leading to urinary glucose excretion and osmotic diuresis. So this is the basic mechanism of SGLT2 inhibitors. By causing osmotic diuresis, it has multiple beneficial as well as side effects. How we are going to see in further slides. So straight away coming to pharmacological properties of important three SGLT2 inhibitor molecules available. We have empagliflozin, dapagliflozin, and canagliflozin. The therapeutic dose, as we all know, empagliflozin is 10 and 25 milligram, two strengths. Dapagliflozin is 5 and 10 milligram. Canagliflozin is 100 and 300 milligram. Starting dose is 10 for DAPA and canagliflozin 100. Administration is with or without food, once a day because it acts for 24 hours. The peak plasma concentration is reached within 1.5 to 2 hours. The best absorption is for dapagliflozin, 78%. And metabolism, all the glyphosins are excreted predominantly by primary glucuronidation. They don't have any active metabolite. The important elimination route is renal for dapagliflozin, whereas it is hepatic, and empagliflozin, whereas it is hepatic for canagliflozin. And selectivity over SGLT1. So as we have seen in the previous slide, it is the SGLT2 molecule which it is supposed to block. But it does block other SGLT molecules also, like SGLT1 receptor. So what is the selectivity for SGLT2? So as we can see, the highest selectivity for SGLT2 molecule is for empagliflozin, whereas the least selectivity is for canagliflozin. And glucose excretion is almost to the tune of 119 grams per day with canagliflozin. So coming to what is the data, what is the effect of gliflozins, especially empagliflozin, on various aspects of, in various combinations on glycemic control, that is HbA1c. So this slide shows that when empagliflozin was added onto an existing diabetes medication, what was the effect in reduction of HbA1c? So this is a pooled phase 3 placebo-corrected trial analysis. As we all see, the pooled data shows that 10 milligram and 25 milligram empagliflozin reduces HbA1c almost up to 0.68, whereas monotherapy was responsible for reduction in up to 0.85% of HbA1c. Now the same data has been replicated in all the combinations, that is metformin, pioglitazone, insulin, and in case of mild remaining impairment. Now what is significant here to understand is, just to clarify, if we see metformin with sulfonylurea combination, here the surprising part is empagliflozin 10 milligram lowers HbA1c to a greater extent compared to empagliflozin 25. There is small difference, but this is important. So what is the practical utility of this? So when empagliflozin is added, there is a drastic reduction in blood glucose because the excess glucose is excreted in urine. And that's why empagliflozin, also like any other diabetes medication, has an effect of or side effect of hypoglycemia. Now, as we all know, amongst all the medications, sulfonylurea are at a very high risk of hypoglycemia. So when the sulfonylurea combination is being used, and after starting empagliflozin, if the sulfonylurea dose is not appropriately reduced, then suddenly increasing empagliflozin may land the patient in hypoglycemia, which is actually counterproductive. So that's why this difference is seen in this slide, because reactive hyperglycemia is followed by hypoglycemia. So we have seen this in practically in our practice that the recurrent episodes of hypoglycemia, instead of decreasing HbA1c, actually paradoxically increase HbA1c because of the preventive or the corrective behavior formed by the patient in terms of consuming more number of meals or repeatedly taking glucose for resuscitation and also counteractive mechanism, defensive mechanism by the body. Now, empagliflozin pooled phase 3 placebo-corrected change from baseline in body weight. So as the excess glucose is excreted, there is osmotic diuresis. So excess water and glucose is thrown out. Glucose is energy. So that's why there is a loss of calories, which results in weight loss. So what is the effect on weight loss in case of empagliflozin? So as we can see, empagliflozin 10 and 25, whenever the strength of empagliflozin is increased, there is more and more amount of weight loss. The only exception being 5-literzone, because 5-literzone themselves are known to cause weight gain due to excess generation of adipose tissue and increasing number of empagliflozin. And 5-literzone is also known to cause high amount of hypoglycemia. So after sulfonylurea, 5-literzone is also at a very significant risk of hypoglycemia, and that's why increasing empagliflozin without decreasing or adjusting the dose of 5-literzone may cause frequent hypoglycemia. So there we have a counterproductive effect, because patient has a behavior. Patient develops a behavior of frequent eating, defensive eating, which actually increases the weight, and that's why the effect of body weight reduction is neutralized. Now, what is the effect of empagliflozin on blood pressure? So as there is an osmotic diuresis, that is excess water is also excreted, definitely there is a reduction in the blood pressure. So the effect on systolic blood pressure was observed. So here, as the dose of empagliflozin was added and increased from 10 to 25, consistent reduction in the blood pressure, increase in the reduction in the blood pressure was observed. Surprisingly, only in case of sulfonylurea and metformin, for the reasons not understood properly. What is the effect on 12-week ambulatory blood pressure monitoring study with empagliflozin in patients with type 2 diabetes and hypertension? So hourly blood pressure monitoring compared to placebo, empagliflozin does reduce the blood pressure, and when the strength of empagliflozin is increased, the blood pressure is further reduced. So it has an important effective role in blood pressure management as well. So thus it is not only a glycemic protector, but also a heart protector. 12-week ABPM study with empagliflozin in patients with type 2 diabetes and hypertension. In diastolic blood pressure, again the same result. There is a consistent reduction in diastolic blood pressure in patients who are on empagliflozin, and as the dose of empagliflozin is increased, there is further significant reduction in the diastolic blood pressure. And very important point, that when the blood pressure is reduced, there is no increase in the pulse rate. So this is a very important observation. Empagliflozin pooled phase 3 data. What is the effect on lipids? So why they are, what is the effect on lipids? Because empagliflozin are often considered cardioprotective. So various effects on various mechanisms of cardioprotection are decrease in blood glucose, decrease in blood pressure, and also changes in cholesterol. So what are the effects on cholesterol for various parameters of lipid profile? So very important effects are empagliflozin increases both LDL, which is called bad cholesterol, and HDL, which is called good cholesterol. So that's why we have increase in total cholesterol after using empagliflozin. But what it does significantly is there is a significant reduction in triglycerides. Now, this difference of increasing the dose is not fully explained. However, this is an observation from the studies. But overall, there is increase in total cholesterol, with both the fractions of cholesterol being more, that is HDL and LDL, and decrease in triglycerides. So overall, a protective component. Effects of SGLT2 inhibitors on glucose control, body weight, and systolic blood pressure as monotherapy, as add-on therapy to various molecules. As we can see, there is a consistent reduction in HbA1c, fasting glucose, body weight, and systolic blood pressure. So all the parameters are consistently reduced by SGLT2 inhibitors. Thus, it is glycemic and cardioprotective. Pooled empagliflozin data shows important identified safety points. Now coming to side effects. So even though empagliflozin is a very good molecule, it has its own important side effects which should be kept in mind while starting the prescription. The most important significant being urinary tract infection. Because excess amount of glucose is excreted, patients are prone for urinary tract infection, especially females. So as we can see, the incidence of urinary tract infection is more in females compared to males. There is also incidence of pyelonephritis, acute pyelonephritis, urosepsis, genital infection, volume depletion. As lot of water is excreted, there is osmotic diuresis. So volume depletion, number of patients with confirmed hypoglycemic adverse events significantly, as I mentioned, especially when empagliflozin is used as an add-on therapy to sulfonylurea or glitazone, pioglitazone, and if the dose is not appropriately reduced, then patients are prone for hypoglycemia. And severe hypoglycemia requiring assistance, though incidence is less, but it is very much present. Empagliflozin and cardiovascular outcomes in patients with type 2 diabetes mellitus at high risk cardiovascular risk. EMPIRIC trial. So what was the outcome in EMPIRIC trial? So EMPIRIC outcome trial, cardiovascular outcomes and death from any cause was reduced. As we can see here, compared to placebo, primary outcome 3-point major adverse cardiovascular events, it was consistently reduced compared to placebo as the duration of diabetes progressed or duration of use progressed. There was significant decrease in CV death from any cause and hospitalization for heart failure. What about renal outcomes? Is it renoprotective? Yes, definitely. So the three important parameters studied were incident or worsening nephropathy, progression to macroalbuminuria, and composite renal outcomes. So in all the parameters, empagliflozin was found to be effective compared to placebo. So that means the worsening of nephropathy was reduced, progression to macroalbuminuria was reduced, and composite renal outcomes were better. So in patients with type 2 diabetes and high CV risk, empagliflozin given in addition to standard of care reduced heart failure, hospitalization, or CV death, with a consistent benefit observed in both those with and without heart failure at baseline. So how early after treatment initiation are the CV benefits of empagliflozin apparent? For post-hoc analysis of EMPIRIC outcome trial, it was showed that CV benefits with an early separation of the cumulative incidence curve occurred as soon as empagliflozin was initiated. That means empagliflozin was beneficial, that is cardioprotective. The aim was also to explore at what time point after randomization benefit became apparent. So it was observed that hazard ratio stabilized as number of patients with events increased over time, and benefit of empagliflozin in reducing risk of hospitalization for heart failure, CV death, or hospitalization of heart failure and CV death only emerged within weeks after treatment initiation in EMPIRIC outcome trial. So these are the exact time durations. How early CV benefits are apparent. So there is a reduction in the risk with empagliflozin versus placebo, which reached significance at day 17. So as earlier within 2.5 weeks, there is a beneficial effect on cardiovascular status of the patient. So there was a reduction in the risk of hospitalization for heart failure, and on day 27, so roughly 4 weeks, there was beneficial effect on CV death, and it sustained significantly throughout the follow-up. And benefit on CV death reached significance for the first time at the end of day 59, that is 2 months. So you can have the beneficial effects as early as day 17. And not only that we achieve this effect early, but also effect remains well within the acceptable range. That means we have a sustained effect. sustained beneficial cardiovascular effect. So CV safety trials are being conducted for each compound within the newer classes because that's a recent requirement by for any anti-diabetic molecule to have CV safety data. So these are the various years and various trials, important ones being Saber-Trimi, Anticos trial, and Carolina trial, and Empagliflozin trial. So SGLT inhibitors modulate a range of factors related to CV risk. So SGLT inhibitors is known to cause decrease in the blood pressure and arterial stiffness. It decreases sympathetic nervous system activity. It decreases weight and visceral adiposity. It decreases glucose and also insulin levels. Decreases albumin loss. Decreases uric acid. Has a protective effect on lipids as seen, and it is also shown to have effect on the oxidative stress, beneficial effect. So these are the multiple mechanisms why empagliflozin is CV safe as a anti-diabetic molecule. So exploratory data showed that SGLT2 inhibitors may have multiple cardiorenal benefits. So as we can see here, hospitalization for heart failure, CV death, and kidney outcome. Across all three major categories, empiric outcome has shown a very important beneficial effect in empagliflozin, whereas canagliflozin, dapagliflozin, and altugliflozin, the effect is less compared to empagliflozin. So having seen the benefits and multiple mechanisms, protective effects, what is the current place of this molecule as far as anti-diabetic molecule is concerned, starting anti-diabetic medication is concerned in patient? So 2018 ADA-ASD consensus report says that metformin is not necessarily considered as first-line drug therapy. Drug-naive patients or patients on metformin, irrespective of level of HbA1c, should be divided into categories. The important factor to be assessed is what is the risk of patient's cardiovascular status, atherosclerotic cardiovascular disease. So especially patients who are at very high risk of cardiovascular disease, patients should be started with SGLT2 inhibitor as a primary therapy or as an add-on therapy, along with GLP-1 receptor agonist. 2019 ESC, that is Endocrine Society guidelines, metformin is not necessarily considered as first-line drug therapy. The drug-naive patients or patients on metformin, irrespective of level of HbA1c, again should be assessed for presence of atherosclerotic cardiovascular disease, and SGLT2 inhibitor starting should be considered. ACC age practical guidelines differ. They say metformin as a first-line therapy, and in spite of starting metformin, if HbA1c is above 7%, then taking into consideration cardiovascular disease risk factors for primary prevention, consideration should be given for starting of SGLT2 inhibitor therapy. So with this, I end my talk because cardiological perspective of empagliflozin will be given by the other speaker. Thank you for patient listening. Most welcome for any kind of questions.
Thank you, Dr. Prashant, for your wonderful presentation. Okay, so the question is, do you think after this EMPEROR-HF trial, does empagliflozin can be a game changer compared to the metformin? If you compare empagliflozin with the metformin, do you think it may be a game changer for this?
Definitely. So I will answer this in two parts. Definitely, since we have a new molecule in our armamentarium, it is a game changer, no doubt. But what we have to take into account is two aspects. One is especially diabetes patients or elderly. Most of the patients in India, if I can say generalized statement, 60 to 70% of them, by the time they land up with our super specialist OPD, they do have underlying cardiovascular factor. So taking that into consideration, definitely empagliflozin is a game changer, no doubt. Of course, when I say about other part, which is the few guidelines which I showed in the slides, I don't necessarily agree that metformin is not a first-line therapy, because we should never forget the basic science in teaching that insulin type 2 diabetes especially is a disease where we have both the factors, the predominant being insulin resistance and insulin secretory defect in later on. So insulin resistance, which definitely has to be taken care by metformin. And practically also we have seen that in patients whom we can't give metformin because of intolerance, or patients in stage 3 or stage 4 class of heart NYHA classification of heart failure, in whom metformin has to be withheld for some time. In such patients, control of blood glucose becomes very difficult. And one third important point is, as I mentioned in the slide, especially in females who are above 50 and 60, a significant number of patients who have important side effects like urinary tract infection, mycotic infection. So that is there, which is not which is overlooked by many doctors while starting. So I have got many patients who are put on medication because this molecule has received a lot of attention in the recent past. But when they come with a lot of side effects. I mean, there are a lot of instances where patients have gone to nephrologists, they have gone repeated urine cultures, repeated admissions, and the simple reason was patient was on the medication. So the moment we take off that medication, patient is fine. So at the end of, to summarize, if I can say, it's not that we have to on one side we have to take care of one factor, but when in the bargain of controlling that factor, we should not invite other problems. So this molecule is very good. This is a game changer, but we have to give due attention to its side effects, and also not neglecting the primary molecule, which is metformin.
Thank you. We have to wait for Dr. Rajesh, sir.
Sure.
Okay.
Sure.
Okay. Hello, Dr. Rajesh. Good evening. Please unmute yourself, Dr. Rajesh. Yeah.
Okay.
Yeah, you can start the presentation. Yes, you are audible. You can start the presentation, sir. Dr. Prashant.
Yeah, can somebody present on my behalf so that I can?
Rohit,
Yes,
Vinay.
Dr. Yeah.
Can you just start the slide share for Dr. Rajesh? Okay. Thank you.
Hello. Okay. So good evening, all. I think we probably have had a pretty good discussion on role of empagliflozin from the diabetology perspective. Now we'll probably be talking from the cardiologist perspective. The interesting part is that probably the SGLT2 inhibitors, when they were launched, they were primarily launched as as an endocrine molecule or a diabetology molecule. But over the last few years, the interesting data that probably has been published give us a very clear idea that this is more of a cardiology molecule. And amongst them, the best data which has come up is with the empagliflozin, which is going to be the next slide, please. So now, if you all know, the EMPA-REG, the Canvas, the Declare TIMI 58, as well as the Vertis CV trial tell us very clearly the hospitalization for heart failure is reduced by 35%, CV death by 38% in empagliflozin group, and kidney outcome is almost 39% reduced. This is probably by far amongst all the SGLT2 inhibitor, the CV death benefit is very large. Even if you look at the ARNI data, it gives you almost a heart failure hospitalization of almost 20 to 25%. And EMPA-REG outcome tells you this is almost 35%. Next slide, please. Now coming on to the primary outcome, 3-point MACE, empagliflozin in the EMPA-REG outcome showed almost a 14% risk reduction. CV death was 38, 32 from death from any cause, and 35% of hospitalization for heart failure. And this was maintained at the end of almost the 4-year data. And when this data was published in 2015, that was the first time we realized that SGLT2 inhibitors have significant benefit in heart failure hospitalization, deaths due to heart failure, as well as CV death and 3-point MACE also. Next slide, please. Now, Framingham Heart Study tells you that some patients who have diabetes, and probably these patients are at a very high risk of heart failure if you follow them for 30 years. Now, heart failure in diabetes is of two types. One is going to be heart failure with preserved ejection fraction, and one is heart failure with reduced ejection fraction. And if you all see in women, the incidence of CV death, CHD, the red bars are definitely higher than the blue bars. So cardiac failure, claudication, only stroke was the one which was probably higher in males as compared to the females. Next slide, please. And another interesting thing is that heart failure is a more common outcome than MI, stroke, and death in diabetic trials. So look ahead, Life, Renal, IDNT, Proactive, Altitude, and various large US registries told us that amongst all, heart failure is a very common complications with patients in diabetes mellitus. Stroke reduction is better, is higher in DM patients. Only thing is MI and death obviously is going to be little lesser. Next slide, please. Now, effect of more versus less intensive glycemic control on MI and heart failure resulting in hospital admission tells you very clearly that the MI, according to the Accord Advance in the UK PDS trial, tells you that if you really have intensive control, you will be able to reduce all of these. But when it comes to admission to hospital or fatal heart failure, Accord was worse, Advance was neutral, and UK PDS obviously had a pretty good benefit as far as with the intensive control. So what does it tell you is for heart failure hospitalization reduction or a less intensive sugar control is better. Now, heart failure outcomes in clinical trials of glucose lowering agents in patients with diabetes tells you very clearly that all of them, when you look at sulfonylureas, insulin, thiazolidine even the GLP-1 agonists which are there, DPP-4 inhibitors also tell you that your hazard ratio doesn't get benefited significantly, but when it comes to the SGLT2, particularly the EMPA-REG outcome, it is below the black bar, below the zero line, it's closer to the 50%. So almost 35-40% reduction of heart failure outcomes. None of the other drugs used in diabetes have got benefit, such a large benefit as compared to the for the heart failure hospital. This is very, very important. Next slide, please. Now, we want to know that evidence of benefits of SGLT2 on heart failure risk in patients with diabetes. The study which was done initially was the EMPA-REG outcome. 11,500 patients was placebo or empagliflozin 10 versus 25 milligrams of this. Inclusion criteria was type 2 diabetes and most important, established cardiovascular disease. The most important thing of the EMPA-REG was most of the people had a secondary outcome. They already had an established CVD and 10% of them had heart failure at baseline too. BMI less than 45, HbA1c 7 to 10 and eGFR more than 30. Mind you, even renal failure patients up to the eGFR of 30 were included in this study. Next slide, please. And what does it tell you? The 3-point MACE reduced by 14%, but the most important thing was the cardiovascular death almost 38%. Non-fatal MI also decreased by 13%. And a non-fatal stroke, there was no great impact, but one of the most important highlights was the 38% reduction of cardiovascular death. Next slide, please. And heart failure outcomes in clinical trials of glucose lowering agents in patients with diabetes tells you very clearly that over 4 years, EMPA versus placebo, there was a 35% relative risk reduction. This tells you also very clearly that the bar separates very, very early, and at the end of 6 months only you see the difference, which is maintained up to 4 years time. So if you start treatment, the benefit of empagliflozin in heart failure hospitalization or heart failure mortality or CV death becomes very, very apparent very, very early during the treatment. Next slide, please. Now coming to the pathophysiological aspects of SGLT2, what do they affect? Number one, as we all know, it acts on the sodium glucose transportase in the distal convoluted tubule, and it reduces the sodium reabsorption and therefore causes natriuresis, improves the kidney function and the cardiorenal physiology also. It reduces preload, afterload and reduction of LV wall stress, and at the same time in heart failure it reduces the interstitial edema. All four factors put together has got great impact in heart failure subset of patients, and it is nephroprotective too. Next slide. Now, prevention versus treatment of heart failure, evolution in progress. So what we are trying to say is there are certain drug treatments that only prevent heart failure, particularly statins, hypertensive, antihypertensive agents like calcium channel blockers, thyroidics, and other drugs like antiplatelet, weight loss, and primary prevention, questionable benefit. But definitely SGLT2 inhibitors reduces the incidence of heart failure. Now, therapies that only treat established heart failure are ARNI, mineralocorticoid receptor antagonist, ivabradine, which is a heart rate reducing agent, and therapies like CRT, cardiac resynchronization therapy, or an implantable cardioverter defibrillator. And therapies that both treat and prevent is ACE, ARB, beta blockers, and exercise, which is there. So mind you, there's only one drug, particularly the SGLT2, which is useful in preventing heart failure. So somebody who is diabetic, high cardiovascular risk, starting SGLT2 drugs very early in the course of therapy is going to be really beneficial. Next slide, please. Coming to the Emperor heart failure studies, which was the next trial sets in with empagliflozin. Next slide. Now, design and the rationale of the Emperor trials of EMPA in patients with chronic heart failure were into two parts. One is Emperor reduced and one was the Emperor preserved. Emperor reduced was reduced EF with EF below or 40% at baseline, elevated NT-proBNP, and the NT-proBNP was dependent on the ejection fraction. The lower the EF, your NT-proBNP requirement for inclusion was less, like more than 600 to 1200 if EF is less than 30, 1000 to 2000 if it is 31 to 35, and 2500 to 5000 if the EF is 36 to 40. Appropriate dose of medical therapy, drugs like ACE, R, beta blocker, oral diuretics, mineralocorticoid receptor antagonist, ARNI, ivabradine, and appropriate device therapy stable for at least 1 week prior to screening was probably one of the inclusion criteria. The person has to be on OMT, optimal medical therapy. Emperor preserved was somebody having ejection fraction more than 40% at screening and no prior measurement of EF which was below 40. Means it cannot be a recovered ejection fraction also. And presence of more than one of the following like left atrial enlargement, left ventricular hypertrophy, hospitalization within 12 months, and elevated NT-proBNP 300 or 900 with atrial fibrillation. Next slide, please. And obviously, let me tell you that India was definitely a part of this particular study. So we have APAC, Europe, North America, Latin America, and Australia, which were probably a part of the study. Next slide, please. Now, what does it tell you is that evaluation of effect of SGLT2 on morbidity and mortality of patients with chronic heart failure and reduced EF, the rationale of design by adjusting the eligibility based on natriuretic peptide level to the baseline EF. Trials will preferentially enroll high-risk patients. A large proportion of patients is expected to have EF less than 30%. An estimated annual event rate is expected to be at least 15%. And this trial was published in October 2019 in the European Journal of Heart Failure. Next slide, please. Now, this is very, very interesting to show that what mechanisms might be responsible for such a striking cardioprotective effect of SGLT2 in HFrEF. So after a screening period, when you give EMPA 10 versus placebo and followed over 20 months and the end of treatment, post-treatment period was 30 days. What did it tell you is that SGLT2 increases the fasting level of ketone bodies, hypothesized to enhance utilization of this efficient molecule in failing heart. However, the finding in experimental studies have provided inconsistent support. Instead, it has been proposed that SGLT2 may slow the course of cardiomyocyte injury and the loss of the sodium hydrogen exchanger 1 in myocardium, whose overactivity may lead to increase in intracellular sodium and calcium, which can impair this particular cardiomyocyte function. Also, EMPA has been shown to inhibit the calcium calmodulin dependent kinase 2, which contributes to the activation of NHE1 in the heart. And actions of EMPA to prevent calcium overload may explain why the drug prevents a time-dependent decline in the systolic cardiac function, leading to overt or pressure overload-induced heart failure. Next slide, please. And what does it tell you is that the composite endpoint time to the first event was probably looked at. Time frame was 38 months, and composite primary event is time to the first event of CV death or heart failure hospitalization in patients with HFrEF. Meaningful addition to the current. So this is very, very important that on baseline HFrEF therapy of ARNI, beta blockers, mineralocorticoid antagonists, and ivabradine, if you add empagliflozin to these group of patients, and the most important part in Emperor was people with or without diabetes was also taken into account. This is very, very important. So patients were diabetic also and non-diabetic too. Next slide, please. Now, are SGLT2s inhibitors the future of heart failure? And the Emperor preserved and Emperor reduced speculated mechanisms were reduced cardiac preload, shift to the ketone metabolism, adaptive cellular reprogramming, inhibitor of sodium hydrogen exchange, improved endothelial function, and reduced cardiac fibrosis. Next slide, please. Coming on to the second aspect is CV and renal outcomes with EMPA in heart failure. Obviously, it also looked at the renal outcomes also with this. And Milton Packer had published this paper in the NEJM 2020 August 29 edition, which has just come up 3 months ago. Next slide, please. ESC Congress also probably had discussed this particular thing. Next slide. So obviously what they are trying to say is EMPA on CV and renal outcomes in patients with heart failure with reduced TF. Next slide. So Emperor reduced trials specified only 3 endpoints to be tested in hierarchical manner. Primary endpoint was of composite of CV death or heart failure hospitalization. First secondary endpoint total first and recurrent HF hospitalization. And second secondary endpoint was slope of decline in the GFR over time. Next slide, please. So obviously the patients had to be on guideline directed medical therapy irrespective of diabetic status, and they should be symptomatic stable HFrEF patients with ejection fraction of below or equal to 40%. Next slide. The goal of the trial was to assess the safety efficacy of EMPA in patients with symptomatic heart failure with HFrEF irrespective of the diabetic status. Next slide. And design of the study was 1:1 fashion with either EMPA 10 or matching placebo in 1800 patients in each arm, and obviously receiving appropriate treatments. Total screen 7,200, total number is 3,700 and 1,860 in each arm. Mean patient age was 67 years and the percentage of female were almost 24%. Next slide, please. More than 18 years, NYHA class 2, 3 or 4, EF below 40%, hospitalization within 12 months was an inclusion criteria. NT-proBNP more than 600 if EF below 30, more than 1000 if more than 31 to 35, and more than 2500 if it was more than 35. This is very, very important that your NT-proBNP was one of the inclusion criteria, not only the symptomatic status of the patient. And the patient was a high-risk patient because he has to have one history of heart failure hospitalization within the last 1 year. Next slide, please. Exclusion is ACS stroke TIA. Patient is listed for heart transplant or LVAD. Any other cardiomyopathy which is infiltrative muscular dystrophy or hypertrophic cardiomyopathy or chemotherapy within 12 months. Severe valvular heart disease was excluded. Acute decompensator is excluded, and ICD or CRT within 3 months were also exclusion criteria. Next slide, please. Salient features: whites were 70, Asians were 18%, North America 11, Europe 36, Asian 13, and Latin America 34. So it was a wide class of across the continents which we had done. Class 2 was 75%, mean ejection fraction was 27%, and 50% had diabetes and 50 did not have it. An estimated GFR was less than 60 or in almost 50% of people. Medications ACE or ARB was in 70, ARNI in 19, MRA in 71, and beta blockers in 94, ICD in 31, and CRT in 12% of patients. Next slide. So principal finding was EMPA versus placebo. The primary outcome there was almost a 25% relative risk reduction. Brilliant. CV death was 8%, and heart failure hospitalization a whooping 31% relative risk reduction. Next slide, please. So primary endpoint was 25%, first secondary endpoint was 30%, and secondary endpoint had 50% reduction in the renal events, which also achieved a success on composite renal endpoint, KCCQ clinical summary score, and the total number of hospitalizations for any reason with a p-value of less than. So this was one of the wonderful data telling that people with HFrEF with or without diabetes, empagliflozin in 10 milligram dosage definitely helps in CV death reduction, heart failure hospitalization reduction, as well as decline of the GFR or decline in the renal failure status. Next slide, please. And time to CV death or hospitalization, if you all know this, in the first 90 days it started segregating. So almost you can say it took almost 2 to 3 months for the graphs to diverge, and there was a 25% risk reduction over a period of almost 800 days, which is there. Next slide, please. Even the CV death and renal endpoints both have statistical significance, almost 25% and 50% reduction in the renal endpoint, as well as the heart failure hospitalization and CV death. Next slide, please. So major implications of clinical practice with this trial was that they will have a major impact on management with chronic heart failure and reduced EF, whether they are diabetic or non-diabetic. And now there is a compelling evidence that SG inhibitors should now be added to the currently recommended treatments for this particular disease. Next slide, please. Primary and secondary cardiovascular outcomes, if you talk about hospitalization, 31%, and death was almost by 8%. So this tells you very clearly that this is the drug to stay, and it is going to come into the guidelines of heart failure hospitalization as class 1A or a class 1B recommendation in future. Next slide, please. So effect on individual components, the primary endpoint 25, hospitalization 31, and 8% in CV death. Next slide. And obviously we already know 30% reduction in total hospitalizations for heart failure, first or recurrent, quite a bit reduced, 30%. Next slide. And obviously EMPA versus placebo related to serious adverse events were 26%. So volume depletion in 10, hypotension in 9, symptomatic in 5, hypoglycemia negligible, ketoacidosis negligible, UTI almost similar. Let us tell you, genital tract is 1.7 versus 0.6. Bone fractures were similar and lower limb amputations were similar. So there is no worry about hypoglycemia. There is no worry about urinary tract or genital tract infections if you advise the patients very clearly what they need to take care of. Next slide, please. And does EMPA lower the risk of CV death or hospitalization? This data tells you very clearly that this is reduced by 19.4%, and almost you can say with the placebo it was 25% incidence, this was 19%. eGFR decline was significant in this group of patients. So among all patients receiving recommended, those in the EMPA group had a lower risk of CV death or hospitalization as compared to placebo with or without diabetes. Next slide, please. Secondary outcomes, obviously total hospitalization was a different, composite renal health outcome different, all-cause mortality also 8% reduction, new onset diabetes type 2 with this was also better. Change in HbA1c was only 0.28 versus minus, so almost less than 0.3, and systolic blood pressure in this arm, the SGLT2 was 2.4 versus 1.7, and confirmed hypoglycemia events were less than 1 to 1.5% in both the groups. Next slide, please. So interpretation is that results indicate EMPA is superior to placebo in HFrEF with EF below 40% over and above the guideline directed medical therapy irrespective of diabetes status. Primarily driven effect is due to reduction in HF hospitalization. Also benefit is there in the renal outcomes. And this trial exactly mirrors the DAPA-HF trial. And every patient with severe LV dysfunction appeared to benefit. Next slide, please. And obviously, even though SGLT2 were introduced for type 2, the results of EMPA trial and others indicate a clear benefit in HF management. But this trial enrolled a dedicated heart failure population with or without diabetes, and these drugs will likely to have a predominant role for future management of heart failure guidelines. Next slide. So guidelines 2019, ESC told us that metformin not necessarily considered as first line. If somebody's drug naive or patients on metformin, irrespective of level of HbA1c, has got an atherosclerotic cardiovascular disease, high or very high CV risk, start with SGLT2 or GLP-1 receptor agonist. And in 2019, ACCHE tells you consider metformin as a first line agent if still HbA1c is above 7. And in patients with other cardiovascular disease risk factors, please consider SGLT2 or GLP agonists as the first line agent. Next slide. So evolving research is an effect of EMPA on body composition by the Embody trial, which is being studied. EMPA is an add-on on transtubular potassium concentration gradient in type 2 diabetes with acute decompensated failure. and EMPA on arterial stiffness, endothelial function, and ventricular arterial coupling in diabetes over 1 year follow-up. These are all the new things probably which they are going to be studying. Next slide, please. So I think to conclude, I would like to say that empagliflozin is an established therapy which can be used in people with heart failure with reduced ejection fraction, with or without diabetes. Over, as of today, it is over and above ARNI beta blockers, eplerenone, as well as ivabradine. And this agent will become the fifth pillar in the management of heart failure with reduced ejection fraction, with significant benefit on CV mortality, death, and significant impact on heart failure hospitalization, as well as quality of life. Thank you very much for a patient.
Okay. Thank you, Dr. Rajesh, for this excellent presentation. There is one question from the audience. The question is, can we prescribe SGLT2 inhibitor in patients without established CVD or having multiple CV risk factors?
Yeah, so without establish ASCVD, if you have a multiple risk factors, somebody is diabetic, hypertensive, dyslipidemic, smoker, becomes a very high CV risk. His incidence of coronary event is going to be in the tune of 20% per year. So in such patients, definitely an SGLT2 inhibitor would be one of the add-on therapies very early, which is going to really prevent heart failure hospitalization, and most important, in these group of patients, it will even prevent decline of renal function. Most of these people, over a period of time, diabetics become CKD. So this drug has got a 50% reduction in the decline of renal function without causing significant hypoglycemia. And I think the most important advantage is that these patients, even if they are not able to come for follow-up, these patients can do very well because sugar is not going to be affected so much. And these patients can even follow up on online basis without even physically meeting. So that's an advantage of this model.
Thank you, Dr. Rajesh. So there is no more questions. So with your permission, can you stop the session?
Yeah, sure.
Dr. Rajesh.
Yeah, I think we can close the session.
Thank you, Dr. Prashant, Dr. Rajesh, for sharing your experience and a wonderful presentation. Yeah, thank you.
Thank you.